All right, let's jump right in with this deep dive. Today we're going to be covering venous thromboembolism,
Okay.
or VTE.
Yeah.
As you know, this is a pretty key topic for the MRCS exam.
It is.
And we're going to break down the essential facts that you need
Okay.
to be able to tackle VTE questions.
Sounds good.
So why don't we start with the definition of VTE?
So VTE includes both deep vein thrombosis, or DVT, and pulmonary embolism, or PE.
Okay, so for the exam, how would you differentiate those two?
So DVT is a blood clot in a deep vein, typically in the legs.
Okay,
And if part of that clot breaks off and travels to the lungs, blocking blood flow, that's a PE.
okay, great. And in the textbook, we've got figures 4.17 and 4.18.
Right.
Can you explain what we're seeing in these images?
So figure 4.17 shows a DVT.
Okay.
It's an ascending venogram where the arrows are pointing to filling defects.
Right.
And these defects represent the blood clot as the contrast flows around it.
Okay.
Figure 4.18 is a CT scan showing a PE. And again, with arrows indicating filling defects, this time within the pulmonary artery.
Perfect. So understanding those images is going to be really crucial for the exam.
Yeah.
Now let's move on to risk factors.
All right.
The textbook classifies these in several ways.
Yeah.
For revision purposes, how should we approach this?
So you need to think about these things systematically.
Okay.
So the categories are primary, meaning congenital,
Okay.
versus secondary, which are acquired.
Right.
Then we have patient-related
Okay.
versus surgical-related factors.
Right.
And then we have Virchow's triad, which explains the formation of a clot.
Could you remind us what that encompasses?
So Virchow's triad highlights the three factors involved in clot formation.
Right.
Issues with the vessel wall, problems with blood flow, and abnormalities in the blood constituents themselves.
Okay, perfect. And then finally, we can categorize risk factors according to timing.
Yeah.
Pre-op, intra-op, and post-op.
Exactly.
So let's unpack some of these categories. Starting with patient-related factors, the textbook mentions age as a significant factor. Why is that?
Well, as we age, our veins naturally lose some elasticity,
Right.
and blood flow can become sluggish,
Okay.
increasing the risk of clotting.
And what about past or family history of VTE?
So personal or family history often indicates an underlying predisposition to clotting,
Okay.
possibly due to inherited conditions like factor V Leiden,
Right.
which is a type of thrombophilia.
Okay, and the textbook lists several other patient-related risk factors.
It does.
Can you just walk us through those?
Sure. So varicose veins, for instance, disrupt normal blood flow, increasing the risk of stasis and clot formation. Malignancy, both due to the disease itself and its treatments, can also increase the risk.
Okay, what about factors like obesity and immobility? How do they contribute?
Obesity is linked to increased inflammation and pressure on veins, particularly in the legs, promoting clot formation.
Okay.
And immobility, such as having a leg in a cast, leads to blood pooling and stasis, increasing the risk.
Right, and pregnancy is also listed as a risk factor.
It is.
What makes pregnant women more susceptible?
During pregnancy, physiological changes like increased blood volume and pressure on the pelvic veins,
Right.
along with hormonal shifts, can contribute to a hypercoagulable state.
And we can't forget high-dose estrogen therapy like the oral contraceptive pill. Why is that a risk factor?
So estrogen can increase the liver's production of clotting factors, tilting the balance towards clot formation.
Okay.
This is also why smoking is a risk factor, as it further compounds the effect of estrogen on clotting.
Right, okay, so now let's shift focus to factors related to disease or surgery itself.
Sure.
So why does trauma or surgery significantly increase VTE risk?
Surgery disrupts the vessel wall, triggering an inflammatory response and activating the coagulation cascade,
Okay.
making clot formation more likely.
Right.
And certain procedures, particularly those involving the abdomen, pelvis, hip, or lower limbs,
Yeah.
carry a higher risk due to the proximity to major veins and increased immobility postoperatively.
And the length of the operation plays a role too, right?
Yes, the longer the surgery, the longer the period of immobility and the greater the disruption to the vessel wall and blood flow.
Right.
This prolonged activation of the clotting cascade increases VTE risk.
Malignancy is listed as both a patient-related and surgical-related risk factor.
It is.
Can you elaborate on its role?
So malignancy itself can release procoagulant substances and damage blood vessels.
Okay.
Cancer treatments, particularly chemotherapy, can also affect blood clotting, further elevating the risk.
Okay, the textbook also lists recent myocardial infarction, paralysis of a lower limb, and congestive heart failure as risk factors.
All right.
Can you explain why?
Myocardial infarction can lead to immobility and damage to the heart muscle, impacting blood flow and increasing VTE risk.
Okay.
Paralysis, particularly of the lower limbs, causes prolonged immobility and stasis.
Right.
And congestive heart failure compromises circulation and can contribute to blood pooling, especially in the legs.
Okay, and finally we have a few less common but important risk factors. Polycythemia, paraproteinemia, homocystinuria, inflammatory bowel disease, and nephrotic syndrome. What's the common thread among those?
They all, in different ways, disrupt the delicate balance of the coagulation system, making the blood more prone to clotting. Polycythemia, for example, increases blood viscosity,
Right.
whilst paraproteinemia introduces abnormal proteins that can interfere with clotting factors.
Okay.
Homocystinuria disrupts amino acid metabolism, affecting blood vessel integrity.
Right.
And inflammatory bowel disease and nephrotic syndrome both involve inflammation and can lead to protein loss, impacting the clotting cascade.
Okay, great. So we've covered a lot of risk factors there.
We have.
And in the next part, we're going to be moving on to VTE prevention strategies.
Okay, sounds good.
So now let's talk about ways to prevent VTE.
Okay, so the textbook also categorizes prevention strategies as it did for risk factors.
Right.
We have mechanical versus pharmacological prophylaxis.
Okay, and again, timing plays a role.
Right.
Pre-op, intra-op, and post-op. Let's start with pre-op measures.
Okay.
The text mentions graduated elastic compression stockings, or TED stockings,
Right.
and intermittent pneumatic compression devices.
Yeah.
How do those help?
So these mechanical methods aim to improve blood flow in the legs and prevent stasis.
Okay.
TED stockings provide continuous pressure promoting venous return,
Okay.
while intermittent pneumatic compression devices mimic the muscle pump,
Right.
squeezing the legs to enhance circulation.
Okay. The text also recommends low molecular weight heparin, or LMWH, as pharmacological prophylaxis preoperatively.
Yes.
What's the rationale behind that?
So LNWH acts as an anticoagulant, reducing the blood's clotting tendency.
Okay.
It's particularly effective in preventing clot formation in high-risk patients.
Besides these measures, are there other important pre-op considerations for VTE prevention?
Yes, ensuring adequate hydration is crucial,
Right.
as dehydration thickens the blood, making it more likely to clot.
Yeah.
Encouraging smoking cessation is also vital, as smoking damages blood vessels and increases clotting risk.
Right.
And for women on the combined oral contraceptive pill or hormone replacement therapy, stopping these medications 6 weeks before elective surgery is recommended due to their estrogen content.
Okay. The text emphasizes early mobilization as a key pre-op strategy.
It does.
Can you elaborate on its benefits?
So early mobilization, even simple activities like ankle pumps and leg exercises, enhances blood circulation, reduces stasis, and helps maintain vessel wall health.
Okay.
It's a simple but effective way to mitigate several risk factors simultaneously.
So moving on to intraoperative measures, the text highlights careful positioning.
Yeah.
Why is that important?
Proper positioning on the operating table, using gel pads and avoiding pressure points, is crucial to ensure that blood flow isn't compromised during surgery,
Okay.
minimizing the risk of stasis and clot formation.
It seems TED stockings and pneumatic calf compression, often called Flowtron boots, are also used during surgery.
They are?
What's the purpose?
Yes, these are often continued intraoperatively to further enhance venous return and prevent stasis,
Okay.
especially during lengthy procedures.
Are there any other intraoperative considerations to keep in mind?
Maintaining adequate hydration throughout surgery is essential,
Okay.
and minimizing the duration of the surgery when possible
Right.
is also beneficial as it reduces the overall period of immobility and physiological stress.
Okay. The textbook mentions neuraxial anesthesia, like epidurals, as a potential risk-reducing factor.
It does.
Can you explain why?
Neuraxial anesthesia can improve blood flow in the lower extremities compared to general anesthesia.
Okay.
And it may have some anti-inflammatory effects that could contribute to a lower VTE risk.
Let's move on to post-operative VTE prevention.
Okay.
The text stresses the importance of early mobilization after surgery.
It does.
How does this compare to preoperative mobilization?
Early mobilization postoperatively is even more crucial than preoperatively.
Okay.
It helps to counteract the immobility and physiological changes associated with surgery, promoting blood flow, reducing edema, and encouraging lung expansion,
Okay.
which is vital to prevent PE.
Besides getting patients moving, what other measures are important in the postoperative period?
Patients should elevate their feet when resting to promote venous return
Right.
and avoid crossing their legs, which can impede blood flow.
Okay.
Pharmacological prevention often continues with LMWH.
Right.
And dose-adjusted warfarin may be initiated in some cases.
Okay.
Maintaining adequate hydration remains essential throughout the recovery period.
Okay.
And of course, TED stockings are often continued postoperatively to further enhance venous return.
The text specifically mentions the modified Wells criteria as a tool for predicting PE.
Yes.
Can you explain how it works?
The modified Wells criteria is a scoring system that uses clinical factors to assess the likelihood of a PE.
How is the scoring system structured and what do the scores indicate?
So each variable in the criteria has a specific point value,
Okay.
and some are weighted more heavily than others.
Right.
A score less than 4 suggests PE is unlikely. Okay.
While a score greater than 4 makes PE more likely.
Can you give us some examples of the variables and their corresponding point values?
Sure. So, for example, clinical signs and symptoms of DVT,
Okay.
such as leg swelling and pain on palpation, carry 3 points each.
Okay.
If an alternative diagnosis is less likely than PE, that's another 3 points.
Okay.
And a heart rate greater than 100 beats per minute scores 1.5 points.
So the modified Wells criteria helps us prioritize which patients may need further investigation for a possible PE.
Precisely.
Okay.
It's a useful tool for risk stratification,
Right.
prompting further investigation like a CT pulmonary angiogram
Okay.
to confirm or rule out PE in those with higher scores.
Now that we've covered the categories,
Yeah.
let's revisit Virchow's triad
Okay.
and how it relates to specific risk factors and prevention strategies.
Okay, go ahead.
You mentioned earlier that the vessel wall, blood flow, and blood constituents are the 3 key components.
Right.
Can you elaborate on how each of these contributes to VTE risk? So the vessel wall, when damaged by trauma, surgery, or inflammation, becomes more susceptible to clot formation.
Okay.
This is because the exposed inner lining of the vessel triggers the activation of platelets and clotting factors.
Okay. And what about blood flow?
Alterations in blood flow, such as stasis due to immobility, create an environment where clots can easily form.
Right.
This is because sluggish blood flow allows clotting factors to accumulate and platelets to adhere to the vessel wall.
Okay. And lastly, the blood constituents.
Abnormalities in blood constituents, like those seen in thrombophilia,
Okay.
increase the blood's inherent tendency to clot.
Right.
This can be due to deficiencies in natural anticoagulants,
Okay.
increased levels of clotting factors, or abnormalities in platelet function.
So understanding Virchow's triad helps explain why certain conditions and procedures increase VTE risk.
It does.
For instance, why is a patient with a lower limb fracture at higher risk?
In a lower limb fracture, you have trauma directly damaging the vessel wall. The necessary immobilization promotes blood stasis,
Okay.
and the inflammatory response associated with the fracture alters blood constituents, making it more likely to clot.
Okay.
All 3 elements of Virchow's triad are in play, significantly increasing VTE risk.
That makes sense. It highlights the interconnectedness of these risk factors.
Yeah.
Now, how do our prevention strategies tie back to Virchow's triad?
So prevention is all about mitigating those 3 risk factors we just discussed.
Okay.
Mechanical methods like TED stockings and pneumatic compression aim to improve blood flow and prevent stasis.
Right.
Pharmacological approaches such as LMWH and warfarin target the blood constituents, reducing the blood's clotting tendency.
Right.
Lifestyle modifications like smoking cessation and early mobilization address both blood flow and vessel wall health.
Okay.
Essentially, each preventative measure has a specific mechanism of action linked to one or more elements of Virchow's triad.
So to effectively answer MRCS exam questions on VTE prevention,
Yeah.
we need to understand not just the list of measures,
Right.
but also how they connect back to the underlying principles of Virchow's triad.
Exactly. It's about understanding the why, not just the what, when it comes to VTE prevention.
The textbook mentions high-dose estrogen therapy, such as the combined oral contraceptive pill, as a risk factor.
Yes.
Can you explain the mechanism behind this?
Estrogen, especially in high doses, increases the liver's production of certain clotting factors, tilting the balance towards clot formation.
Okay.
This is why it's crucial to stop these medications several weeks before elective surgery to minimize VTE risk.
That's an important point to remember for the exam.
Yeah.
Now, the text repeatedly emphasizes the importance of early mobilization.
It does.
We've touched upon its benefits.
Yeah.
But can you summarize why it's considered a cornerstone of VTE prevention?
So early mobilization is a simple yet powerful intervention that targets multiple risk factors simultaneously.
Right.
It promotes blood flow, reducing stasis, and the likelihood of clot formation. It helps maintain vessel wall health by encouraging normal blood flow and reducing inflammation.
Right.
And it also encourages lung expansion, which is particularly relevant for preventing PE.
So early mobilization addresses all three components of Virchow's triad.
Precisely. It's a multifaceted intervention with significant benefits in VTE prevention.
Now let's turn our attention back to the modified Wells criteria.
Okay.
Do the criteria themselves reflect the risk factors we've been discussing?
Yes, they do.
Okay.
The modified Wells criteria cleverly incorporate those risk factors to predict PE risk.
Right.
For example, clinical signs of DVT directly point to vessel wall damage and potential clot formation.
Okay.
Immobility and recent surgery relate to blood flow stasis.
Right.
And a history of DVT or PE, along with malignancy, can signal abnormalities in blood constituents.
Right.
Even factors like tachycardia and hemoptysis,
Yeah.
while not direct indicators of thrombosis,
Okay.
can raise suspicion in the context of other risk factors.
So the modified Wells criteria isn't just a random set of variables.
No.
It's a carefully constructed tool that reflects our understanding of VTE risk factors.
Exactly. It embodies the principles of Virchow's triad
Right.
and provides a practical framework for assessing PE risk in clinical practice.
Okay, great. So this deep dive has highlighted the importance of understanding the underlying mechanisms of VTE.
Yeah.
Not just memorizing facts for the MRCS exam.
But that's important.
Applying this knowledge to clinical scenarios will be crucial for exam success.
Ill.
So in the next part, we're
Yeah.
going to go through some practice questions.
Okay, that sounds good.
Okay, so let's apply this knowledge to some potential MRCS exam questions.
Okay.
How about this? A 65-year-old man is scheduled for elective hip replacement surgery.
Right.
Which of the following is the most significant risk factor for VTE in this patient? A, age B, history of smoking, C, previous DVT, or D, obesity?
So the answer is C, previous DVT.
Okay, and why is that?
Whilst age, smoking, and obesity are all risk factors for VTE, a previous DVT carries the highest risk. It suggests an underlying predisposition to clotting, making this patient high risk.
Okay, let's move on to another scenario. A 30-year-old woman is recovering from an emergency appendectomy.
Okay.
Which of the following is the most appropriate postoperative VTE prevention strategy? A, graduated elastic compression stockings alone. B, intermittent pneumatic compression alone. C, low molecular weight heparin alone. Or D, combination of graduated elastic compression stockings and low molecular weight heparin.
The most appropriate answer here is D, the combination of graduated elastic compression stockings and low molecular weight heparin.
And why is that?
This combined approach addresses both mechanical and pharmacological prevention
Okay.
and is standard practice for moderate to high-risk surgical patients.
The MRCS exam really emphasizes applying knowledge to clinical scenarios.
It does.
As you continue your preparation, think critically about how you would tailor VTE risk assessment and prevention for patients with multiple comorbidities.
Yeah, that's key.
This integration of knowledge will be crucial for your success. So remember, a deep understanding of Virchow's triad, risk factors, preventative measures, and the modified Wells criteria is crucial for excelling in your MRCS exam.
It is.
Best of luck with your preparation.
Thank you.